Let's get started. So A is not just about airway, and to me it's about asking for help, looking at a patient, recognizing that most of the time, yes, we might be able to take care of this patient, but you're never gonna be faulted for asking for help early. B is about breathing, and it's not just about breathing for the patient, it's breathing for yourself. So you need to control your anxiety and consider doing tactical breathing. You can look that up. Breathing is about oxygenation. It's not about placement of an endotracheal tube. So you're going to oxygenate that patient by whatever means, high flow nasal prongs. It might be placement of a supraglottic device. Ultimately, it's intubation, but B does not equal intubation. B is all about oxygenation. C is circulation, but first want to address the issue about C-spine and all the worries we have about C-spine and airway management. Just think about it. Patients in a big crash, you know, at 80 kilometers an hour, they're slumped over in their vehicle, and then we straighten them up and extricate them and transport them. What's the chance that during your resuscitation airway management that you're all of a sudden going to pit the patient? Pretty low. I'm not saying disregard C-spine, but I think we probably harm more patients by worrying about C-spine and delaying what needs to be done in terms of airway management. C is obviously about circulation too, so it's about access, and access is not IV only. I talk about the rules of two, so you've got 2 minutes, 2 people, 2 different sites to get IV access, and if you don't get IV access in that situation, you're going to move to IO. If you're one person, one try, one place, 1 minute, and then go to IO. It's warmed fluids, it's tranexamic acid, I can never say that properly. It's about instituting massive transfusion protocol. It's about binding the pelvis and splinting long bone fractures, and it's about doing a fast and deciding whether they need operative intervention. Your D is yes, it's disability, but it's in my mind, you're thinking again about what's your disposition. Is this person going to stay, or are they going to go? Are they going to CT? Are they going to the OR, or are they going somewhere else? Think of disposition early, activate whatever support mechanisms you have, whether it's air medical transport or critical care transport to another location. And then the E is, yes, it's about environment, making sure your patient's appropriately warm, but it's also, again, about remembering an exit strategy. It's about remembering to park your egos and remember it's the patient first, and think about the common errors that happen as part of the A, B, C, D's, and E's. So that's pearls on a page. I don't know how long that took, and a snowy, beautiful day here in Halifax, Nova Scotia.